morning, everyone. Hello, welcome, and I really appreciate everyone who's taken the opportunity to call in for this morning's special conference call. Good morning to those of you in the United States, and good afternoon to our friend and our colleague, Dr. Sigal Sviri in Israel, who's joining us via this Zoom video call. My name is Josh Rednick. I have the pleasure of serving as the Chief Development Officer for Hadassah here in the US. And again, it's really an honor to welcome all of you to join us today for this really interesting learning opportunity about how the COVID-19 outbreak is affecting our colleagues in Israel and our hospitals and the people who are being treated there. I do want to start by taking a moment to offer my sincere appreciation to all of the major donors who we have on this call, for all of the donors we have on this call, for supporting Hadassah. Really, it's only because of your support of HWZOA and Hadassah Medical Organization that our medical staff, people just like Dr. Sviri, can do the work that they do, saving lives every day, and in particular, saving lives today, given what's going on in the world. Thanks to their medical research, innovative techniques, new therapies, and much more, we're able to carry out the mission of this organization on a daily basis. So it's no surprise to any of you that today's topic is the COVID-19 pandemic. And in this call, which is the second in our series on this for major supporters of our organization, we're going to be taking some time to explore a bit of a different side of this fairly unprecedented health crisis. As those of you know who joined us in our previous call about 2 weeks ago, we had the really great opportunity to hear from Professor Alon Moses, a leading infectious disease doctor at HMO and in Israel and around the world. And he was able to give us insights into the virus itself, how it's spread, what some treatment options for it are, and more. Having Dr. Sviri with us today will be a bit of a different perspective. She's an internal medicine specialist, and she is the doctor right now in charge of the intensive care unit that our team in Israel has assembled rather quickly inside of the until recently vacant round building at our Ein Kerem campus. She is the director of intensive care at Hadassah Hospital Ein Kerem, and much, much more. She also recently, a few months ago, became not only Dr. Sigal Sviri, but Professor Sigal Sviri. So Sigal, from all of us to you, Mazel Tov. Professor Sviri is a world-leading expert on intensive care, and she's going to be sharing, as I said, really on-the-ground insights and experiences working on this virus and with patients who have been infected over the last couple of weeks. In addition, we should point out that Hadassah hospitals right now are currently doing all they can to treat the most critically ill patients. And she can also talk with us a little bit about how patients are responding to that treatment. She'll also be providing some detailed updates as well as some images and a little bit of video capture from the newly created COVID-19 quarantine center within the round building. And at the end, we will have some time to address questions. I do want to also point out that beyond her good work at HMO, Professor Sviri is also the treasurer of the Israel Society of General Intensive Care. After graduating from the Hebrew University Medical School, she did her residency at Hadassah University Hospital, and she has been a lecturer and a professor at Hadassah for well over 20 years. Now, in terms of the Q&A section of this call, we are going to have time in the second half of the hour or so for questions from all of you. Some of you have submitted questions in advance, and we're grateful for that. I have those questions already in front of me, and I'll be referring to them later in this discussion. But if you do want to raise a question during the call that we can put into a queue and that we can attempt to get to later, I want to point out a couple of features about how Zoom works, so you know exactly how to have your questions come to us, those people who are managing this call today. So for those of you who are on a computer or a tablet or even on your phone, if you are on a computer and you move your mouse button, or if you're on a phone or a tablet and you touch your screen, there will be a series of options that should pop up. And down at the bottom, for those of you on computers, you'll see a little area that says Q&A. If you click on that, you will be able to open up a small chat window where you can type questions in. Our team will receive and sort and prioritize those questions, and we will do our best to get to all the questions that we can today. Two quick caveats before we jump in. One, as you might imagine, Dr. Sviri is likely one of the busiest people on the Ein Kerem campus right now. Her time is limited, so we will do our best to address all of your questions, but we do want to limit today's call to just an hour. And the second thing that I must note that we always do in calls like this is that as much as Professor Sigal is here to share with us a lot of insights and information, one thing she cannot do is provide personal medical advice to anybody on this call. So if you do have questions, please do your best to keep them general in nature and not specific to your own situation. So with all that said, we are really thrilled for everyone being able to join us today, and we want to welcome Professor Sviri. Thank you again for this opportunity to chat with our most important supporters, and they're looking forward to hearing from you and not from me. So why don't you please take it away?
Thank you very much, Joshua. It's a pleasure for me to be here and talk to you. It's a very stressful time for me, but I think it's important that we share some of our experiences at Hadassah. I've had the privilege to meet some of you in New York in July, and so it's like one big family. I think that this pandemic has caught us at a time where medical resources are enough but limited, and we were not ready to stretch out endlessly to admit thousands of patients who are critically ill. And I must say that I think we are all in a little bit of shock, and we will probably be in post-traumatic distress syndrome after this is all over. But one thing about Israel in general and Hadassah in particular is that we are ready to join forces in crisis. We unfortunately are used to crisis situations, whether it's terrorism or war or a pandemic. So we really did our best, and we are doing our best to save people's lives while we are struggling to use up our resources and to even allocate different resources to different places to enable us to treat these patients. And don't forget that these patients have to be in complete isolation from all the other patients. So there are two challenges for us. One is to isolate the coronavirus patients from all the other patients to keep them safe, and of course the staff safe. And the other challenge is to find the resources, whether it's human resources or equipment, to treat them and to save their lives. I think we started thinking about how we're going to deal with this corona crisis during January, when more and more reports were coming in, mostly from China, about this strange virus. Initially, I must say, some of my colleagues, were a bit, they brushed it off as just another influenza virus. It's not going to be very, very difficult to deal with. Most of the patients will probably do very, very well, and we will just have to kind of sail through it and reach the end as soon as possible. I was a little bit more pessimistic, because I knew that if many people will need respiratory support, ventilation support, intensive care support, we will not have that capability in the current situation. It's one thing to allow a bed or two in your ICU for a car accident or a severe infection. It's another thing to set up a whole parallel hospital for patients who need to be isolated and treated just as well as all the others. I must say that the management took things very, very seriously, and towards the end of January and the beginning of February, we started talking about a corona team. We set up a corona team made up of management, but especially infectious diseases experts, internal medicine experts, and intensive care specialists. And together we started thinking about how and where we're going to admit and treat these patients who are probably going to start coming in as people are going to return from abroad after they've caught the virus somewhere, whether it's China or Europe or anywhere. I think it took us about 2 weeks until the second half of February to understand that we're in a rush. There is no time to wait and see what happens in other places. By that time, the tragedy in Italy was becoming more apparent, and we see ourselves a little bit similar to Italy. We're both Mediterranean. And I think the tragedy in Italy turned the corner in the eyes of the Ministry of Health in Israel and the management in Hadassah. Because if it can happen in Italy, it can happen in Israel. And I think when more and more reports were coming in about how there aren't enough ventilators in Italy, how they're letting people go because they don't have enough ventilators, and the fact that people are dying by the hundreds and the thousands, started a little bit of a panic, a good panic, not a bad panic, a good panic in Israel and in Hadassah. And the Ministry of Health actually controlled and managed the number of beds and facilities that each hospital in Israel has to provide for potential coronavirus patients. I will show you in a minute how we built the unit. I just want to say that Jerusalem has a potential for a catastrophe because of very, very highly populated areas in Mea Shearim, in ultra-Orthodox areas, and also in East Jerusalem. Very close living conditions with many family members. And we are now seeing the impact of Purim parties, of weddings, of celebrations that people did not internalize, that should stop. We are now seeing the results of all of these interactions because the virus takes time to appear. The virus can sit in the body for a week and two, and the person can feel that they're fine. And then all of a sudden, within a few days, they start becoming symptomatic. They rest ventilation, and this can happen in even a day or two. So the transition from somebody who is feeling quite healthy to the point of requiring intensive care and ventilation can happen very, very quickly. Hello, can you hear me?
We have you back, Sigal. Please keep going.
Something happened. So what happened at Hadassah? At Hadassah, this team of specialists decided to build two areas of extremes. One area was an area that people who have been infected with the virus but feel quite well need to be quarantined from the rest of the population. And it was really like a hotel or a babysitting area where people were you know, actually quite fine, and we were just monitoring them. This opened about 15th of March, and it was filling up very, very quickly. And there was more pressure on us to build an intensive care unit that could treat the critically ill patients that would require specialist treatment. So we put together, I think it was within a week, we put together a group of technicians, of builders, of respiratory technicians, of people who came and did rounds with us. I think I can show you the PowerPoint. Josh? Yeah, can you see?
You're going to want to click on that share screen function, Sigal, and then you can pull your PowerPoint presentation up for the audience. While Dr. Sviri is doing that, I just want to note that we have been gathering some of the questions that you've been sending to us. and filling out our list of what we'll talk about in the second half of this call. But I'm going to turn things back over to Dr. Sviri.
Okay, can you see now?
Give you a sense of what's going on. Yes.
So this is the area we were facing in the round building on the 8th floor where the cardiac care unit used to be. It was evacuated. It was being we were getting ready to actually start renovating the old building on that floor. So as you can see, everything was torn down, the floor was taken off. There was no infrastructure there apart from the walls. When we looked at it, nobody could believe that this could actually be turned into intensive care unit within less than a week. It looked absolutely terrible. If we have a look now, we can see that we decided that the beds should be divided by not exactly walls, but partial walls, so that we can keep privacy and infection control. And you can see here that we started looking for monitors, ventilators, beds, anything we could spare from the functioning hospital to allocate to this unit, because we did not have time to order new equipment. And in fact, I must say that countries were shutting down their ability to provide other countries with ventilation and monitoring equipment because they needed it for themselves. So actually, nobody really is selling ventilators and monitors, at least not from Europe. And we had to deal with what we have. So you can see that finally we were able to set up 6 intensive care beds. This is within a week. You can see at the background the monitor. You could see that all the technicians had to put in oxygen gases, air gases, high pressure gases, adequate electrical facilities. This is a mechanical respirator we received. And this was the end result. And I will show you the video, or Josh will show you the video at the end. A fully functioning intensive care unit within 1 week. Here we can see that outside of the intensive care unit, there is a monitoring area. The monitoring area has a platform to see all the patients that are videoed inside the unit, and we can zoom in and zoom out to see how they're breathing, what the parameters are, so that we don't have to go in and out every time. And this is the central monitoring station that can show us the vital signs at each moment. Here you can see the way we have to protect ourselves. We have to wear personal protective equipment by the standards defined by the Ministry of Health. So we have headgear, we have eye protection, we have the N95 masks, we have waterproof aprons, we have double gloves, and we have protective gear for the shoes. And it is very important that everybody who has to protect themselves, and we call it donning, has to be monitored by somebody else to see that they're doing it in the right order and in the right way, that the mask fits well, and that nothing is loose and nothing will come off. Because when you're in the isolated area, you cannot change anything, you cannot take anything off, and once you're in, you're in. Here we can see the very, very intensive courses that we are running for all young doctors. We started off by teaching ventilation to internal medicine doctors and emergency department doctors, but today we started training the surgical physicians. You can imagine an ophthalmologist being taught how to ventilate a patient, just in case we will have too many ventilated patients and not enough doctors. So there's a lot of courses, instructions, demonstrations going on. Here we can see a multidisciplinary discussion in the control area about one of our patients who has cardiac failure and arrhythmias. We can see the cardiologist and the intensivist all looking at the monitors so that we can make decisions but don't have to go into the isolated area. And here you can see me holding the McDonald's bag that we get every day into the coronavirus area. People donate food, restaurants send food. We are spoiled rotten, and we're eating too much, but I think it's one of the ways to manage this stressful situation. Josh, maybe you can show the video now.
I'll be happy to. Give me just 1 second to change one thing here for everyone who's on, and I'll pull this video up myself. So this is a video that Dr. Sviri sent us earlier. Hopefully you all can see this because my screen is now being shared. And this is sort of a bit of a walkthrough that Dr. Sviri was good enough to share with all of us that shows what the finished product looks like. And I'll just point out again that the team at HMO was able to assemble basically an entire intensive care ward in just under 1 week, which from my vantage point is extraordinary. So let's watch this video and then we can come back to Dr. Sviri.
You could see the technicians working. This was just before we opened. We had to think about everything in advance because once, can you hear me? Yeah.
Yes.
Okay. Once the unit was opened with corona patients, then nobody could go in and fix anything. So we had to think about every single detail before we opened. This is a blood gas machine. We had to think about what kind of communication we can have with the people inside. They're not allowed to talk on their cell phones. We needed to think about computers. We needed to think about cellular phones dedicated to that area, fax machines, printers, everything that could enable us to communicate with the people inside in a way that we don't have to rush in every time they need something. And it's a fully controlled area. Nobody can just walk in. Everybody has to be properly protected before they go in. So I want to tell you a little bit about the patients that we have in the unit. The unit is now full. We have 6 patients in the unit, and I must say that not everybody is very elderly with multimorbidity. We have one 34-year-old man who had a baby boy a couple of weeks ago, and he insisted on having a birth, and he invited 60 people to the birth, and unfortunately someone was infected with corona and managed to infect the father, who's now ventilated in the ICU, his wife, who's critically ill but not ventilated in the other corona department. The little baby is being tested, and the rest of the family is quarantined. So we see the repercussions of people who are not following the recommendations. We have another 40-year-old health worker from India who was aiding an elderly patient in a chronic facility where one of the social workers came back from France, I think, and infected several elderly patients. Several of the elderly patients unfortunately passed away from the virus, but the healthcare worker, can you hear me?
Yes.
Okay. The healthcare worker was also infected and she was critically ill. We now have 3 neighbors from the same building who each one of them caught the virus. One of them is elderly and he's ventilated, and I hope we can save him. And we have another 57-year-old man who has heart failure, and he is also in critical condition. So we have really the full spectrum of patients. Not all of them are very elderly. And now in Israel, we have about 6,000 positively diagnosed patients. We have 22 deaths, and the range of deaths is from 49 to 97. So it's not only the very elderly that succumb to this virus. I would like to say that the amount of patients who are coming into Hadassah is increasing every day, and this week we had to open another corona department, a 38-bed department. Patients there are pretty sick, and we probably need to plan for many more ventilated patients. We have now included the anesthesiologists in our efforts to be able to treat all these patients, and everybody who can help is helping. I really have not encountered anybody from the medical or the nursing or the management or technicians who said no to me. And we really are working together to try and handle the amount of patients that are coming in every single day. We desperately need more life-saving equipment. We need monitors, we need ventilators, we need syringe pumps to give drugs. We need ventilation and intubation equipment so that we can safely intubate the patients without risking the treating physicians and nurses. And really, we are in great shortage of this life-saving equipment. So I think it's very important that we remember that we still have a lot of work to do, and the end is not near. So Josh, I think we can...
Thank you so much, Professor Sviri, for sharing with us all of those updates, some of which I think are mind-boggling to consider how quickly we were able to get the intensive care facility up and running in the Round Building, and some of which I will say personally are quite sobering when you describe some of the stories that you did about the patients you're caring for, what their ages are, which tends to dispel some of some of the notions people tend to have about COVID-19, and just how it's impacting the community around our hospital, around the city of Jerusalem, and for all the people of Israel. So we're going to move in just a moment into an opportunity to ask some questions of Professor Sviri. I do want to make a couple of quick sort of housekeeping comments and updates for all of you before we move into that. So first, I really appreciate everyone sticking with us. We've been addressing some of your questions in the chat, and we also will continue to address some of the questions you've been raising in the Q&A function of Zoom. In addition to that, I couldn't have said it any better than Professor Sviri did as she wrapped up her opening comments, which is that what HMO is doing right now, in my opinion, is pretty extraordinary, and in many ways, because of the unique population of Jerusalem, as Professor Sviri described, they're at something of an epicenter for this outbreak within Israel. The needs are significant, and as I think all of you know, we've begun an emergency fundraising effort to provide as much support as we possibly can. A lot of what we are focusing on right now is raising funds to meet the exact needs that Dr. Sviri began to describe, which is largely around equipping the ICU with everything they need in order to care for patients, and to make sure that the doctors and the nurses and the staff who are providing that care are as protected as they can be themselves. For those of you who are following the news stories here in the States, I think you all know just as well as I do that one of the key concerns right now is keeping the healthcare providers themselves healthy, because without that, things can go south very, very quickly. In terms of providing support, for anyone who may be interested in that, just a couple of quick updates before we move into Q&A. One, we're grateful for any support that our donors can provide right now. And the people who are on this Zoom meeting right now represent some of our most generous donors over the years, people who really love Hadassah and love our hospitals in Israel. If you are interested in providing support, the best way to go about doing that right now is to engineer a conversation with your local major gifts officer. All of them are ready. We try to keep feeding information to them as frequently as we can so they can answer questions the same way Professor Sviri and I can. And the best way to really move forward on making an investment in providing this kind of support to HMO at this time is to start the conversation with your local director of development. In addition to that, I do want to point out that a small group of us, including our colleagues at Hadassah offices in Israel, particularly Gidon Melmed, who's on this call, and our friend and colleague Audrey Shimron, have been instrumental in working with a donor who is finalizing plans to make a matching donation that will match all or some of what our donors all over the world provide in support to HMO at this critical time. This is not only going to be able to match donors here in the US, but also donors from Hadassah International, and to our knowledge, donors in Israel as well. And there have already been several individuals, foundations, and corporations that have stood up and provided support to HMO already. As we finalize the details on that matching gift, we will share it with all of you because we believe it can help to inspire further giving from within our traditional giving circles, as well as in this unique time, potentially from some new people to engage with Hadassah as well. I do want to note, and I think I would be remiss if I didn't say so, that as we discuss fundraising opportunities at a unique time like this, we are trying to be very mindful of the fact that this is not a crisis that is only impacting Israel. It's clearly impacting the United States and the rest of the developed world, and even less developed world, in some very significant ways. We've all seen the precipitous drop in the value of the capital markets. We all know the impact that has on our personal assets and how we feel about giving and much more. But as you've heard from Professor Sviri throughout this call, and as you saw with some of the images she was able to share, HMO has ramped this work up incredibly quickly, and the needs are significant. And if you are able to help us during this extraordinary time of need, we will be incredibly grateful. So with all of that said, Sigal, I want to turn things back and represent the audience in providing some of their questions to you. Because of this format and because of the fact that we have a significant number of people participating, unfortunately, we can't have those participants raise questions themselves. So I will sort of serve as the MC, so to speak, for this part of our discussion, and I will pass some of their questions on to you. So the first question that I do want to start with is, what, if anything, you and your colleagues at HMO are finding to be successful in the way of treating COVID-19 right now? If you could quickly talk to us about that, and then we'll raise a few other questions as we go forward.
So this is very frustrating because nobody knows enough about this virus to say what is actually going to help, and there isn't time to develop randomized controlled trials to test all these medications. The reports from China described some success in treatment with anti-malaria drugs, which could reduce the replication of the virus in the body. And every patient that comes to the intensive care unit or is developing respiratory symptoms receives hydroxychloroquine, which is an anti-malarial drug. It is provided in high doses. It can cause prolongation of QT, which is something that we see in the ECG and can cause arrhythmias, but we see very, very few side effects for this drug. So every patient gets this drug. The other drugs that we provide are antibiotics or anti-HIV medications that can actually, even if they don't work themselves, can actually increase the levels of the hydroxychloroquine because they compete on the same enzyme that metabolizes the hydroxychloroquine. So once they compete, the hydroxychloroquine is metabolized less. But there are some reports that the drugs themselves, the anti-HIV drugs, can actually also help us reduce the replication of the virus. Some of the patients receive normal, regular antibiotics that we give for pneumonia because it's very hard to differentiate whether the patient only has coronavirus or has coronavirus plus a bacterial infection. So some of the patients receive also antibiotics. There is evidence that steroids are bad for coronavirus patients because they reduce the immune system, so we try to avoid these. But these are the major drugs that we provide. Not a lot of evidence supporting vitamin C or zinc. There are esoteric reports that vitamin C helps the immune system and is an antioxidant, but we have not started providing vitamin C in high doses at the moment.
Understood. Thank you. One follow-up question on that front. Several of us here in the States have seen some news reports about whether it is more or less safe to take ibuprofen at this time as opposed to perhaps acetaminophen or aspirin or some other kind of pain-relieving medication, which many of us, especially those of us who are a bit active, tend to take on a more frequent basis than maybe we should. So could you speak to that a little bit for us, Sigal?
So it's an interesting question because when I was a young doctor, my mentor, Professor Linton, always told me, don't give non-steroidals if your patient has a bad infection, because non-steroidals are not anti-inflammatory. And by saying anti-inflammatory, we treat the bad inflammation, but also the good inflammation, because the body reacts to bacteria or viruses or other diseases by an inflammatory response. It's a good response. It's the war that the body starts to fight the virus or the bacteria. So the same probably relates to the coronavirus. There is no proof that non-steroidals actually made patients die from the virus. There are reports that it caused renal failure, which non-steroidals cause, especially in patients with diabetes and chronic renal failure. So it may have made some of the patients worse when they took the non-steroidals. So if you ask me, I would probably not prescribe anti-inflammatories, because I think the body needs to fight the virus, and the body does not need medications that prevent it from fighting. But it's not clear-cut that it's actually very, very dangerous. We in Israel have Optalgin, Dipyron, which you don't have in the States. So really acetaminophen, Tylenol is probably the best antipyretic options at the moment.
Great, thank you so much. One of the questions that I've actually seen pop up quite a bit over the last couple of days, both in just following this news story here in the States, as well as what I'm reading online, and it also was raised by one of our participants, is how it is that the COVID-19 virus can cause such a rapid deterioration in a patient. It's almost like, and Cheryl Sperper raised this question in the Q&A section. Hi, Cheryl, and thank you for participating. Cheryl wrote, it's almost like flipping a light switch, where the patient can go from being reasonably stable to being very, very ill in a very, very short period of time. So what do you think it is about this virus that is making that happen?
Well, what we see is something we call a cytokine storm. A cytokine storm means that the immune cells that are responsible to fight the virus produce a lot of substances that can actually cause damage to the body. And the virus, because it replicates in the lung, causes a cytokine response in the lung. And the white cells, the inflammatory cells that produce the bad substances in response to the replication of the virus in the lungs, actually cause damage to the lungs, what we call ARDS, respiratory distress syndrome. And the cytokine storm in the lung is probably what makes the bilateral diffuse disease in the lungs instead of having just a local pneumonia in one lobe or another, in one lung or the other. It's a bilateral diffuse lung injury, which causes very rapid deterioration, both from the virus, but mostly from the immune response.
Got it. Thank you. So next question we're gonna go to. We've been talking a lot about setting up an ICU and equipping it. We've been talking about what medications and treatments you and your team have been finding to be helpful. I want to change direction just a little bit for a moment to something that is potentially at least a little bit more sensitive, but I think no less important for all of us in considering the provision of care. And that's how decisions get made about who gets treated when there might be limitations on the amount of equipment or medications or staff who are available to provide those treatments. I would imagine, just as a layperson, Professor Sviri, that there are ethical questions that come up with all of this that you must either already be considering or should things continue to worsen, are soon going to be considering that much more. And I was hoping, and so was our audience, you could speak a little bit to what it's like to find yourself in the position to have to wrestle with decisions like that, how you lead your staff on decisions like that, whether there's an ethics committee at the hospital that has to weigh in on these things, and more.
Okay, so this is a very important question, especially because of what we're seeing from Europe, where there have been reports that people who are over 60 or 65 are not even connected to a mechanical ventilator, and some of them are even disconnected from the ventilator to make the ventilator available for somebody younger. I think this is a very, very sensitive issue in Israel. As we discussed even in New York, we are really not allowed to end life acutely. We are not allowed to withdraw life support if a patient needs it. And Israeli society, not only religious Israeli, but Israeli society as a whole is very sensitive to end-of-life decisions and limiting life support. So Hadassah has, with the backing of the Ministry of Health, has appointed a committee, an ethical committee, to define the indications for intensive care, for life support, so that we can actually use up our resources in a way that we do not have to face major ethical decisions once we've started. So we would rather withhold intensive care support to somebody who's very elderly or frail or has a lot of comorbidities, and not withdraw once we've started. This is very problematic in Israel. It's not problematic in Europe and not so much in the United States, but it's very problematic in Israel. And I don't think there are many Israeli doctors that would be able to actually disconnect somebody from life support. So we have to be very careful. And the experience we've had in Hadassah is that the patients who died at Hadassah were very elderly, were very frail, and with regular close discussions with the families, because they themselves could not communicate, we reached a common decision that these patients are not going to be resuscitated. The problem is that, as I said before, there is a very, very large Haredi community on its way with Corona. And end-of-life issues there are going to be much harder. Probably this committee will have to help us define the criteria where we are going to say we are not going to resuscitate a person if we think the chances are very slim that they will survive. I really don't envy anybody who has to make these decisions. And I think one of the reasons that the Ministry of Health is very, very panicking at the moment is because of the fact that we don't want to reach that point and we don't want to be facing such difficult decisions.
Thank you, Professor Sviri. I personally found that answer to be incredibly insightful and thoughtful, and I'm imagining that those people who are on our call with us today did so as well around a particularly sensitive issue. Let's transition for a moment back to the establishment of this new ICU facility within our historic Round Building. You've talked about different numbers of beds and different floors, and I wonder if you could kind of bring all of that together and tell us where we are right now about the capacity of all the intensive care facilities that we have currently in the Round Building, and to what degree you think that's going to need to expand, and if it does expand, what you ultimately think the capacity would grow to be.
Okay, so this is also very interesting because this virus is stronger than all of our plans. It's very difficult to plan because the virus is quicker. We started off with a 20-bed ward for the easy patients, as I said before, the ones that are really, really stable. Then we opened the 6-bed ICU for the ones who are critically ill. Those filled up very, very quickly, and we understood that we have to open more areas. So we opened a 38-bed internal medicine ward. It formally opened a few days ago, but today we expanded it from 18 beds to 32 to 34 beds. It's nearly full at the moment. As we speak, it's filling up. People are flooding into the emergency departments. Once they're swabbed and they're positive, they have to go there. So we're going to probably be full by the end of the week. Next week, we're going to open another 20-bed area on the 5th floor of the Round Building to be able to admit more patients there. And then in about 10 days' time, we're going to open another medical ward and probably equip it to ventilate about 20 patients, at least 20 more patients. And if this is not enough, we're talking now about nearly 100 beds. If this is not enough, we're going to take over the old operating theaters in the old building. That you know that the new Davidson building has very nice new modern operating theaters, but we also had operating theaters in the old building, so we're going to use these together with the old recovery. We probably be able to ventilate 50 more patients. So the Ministry of Health is expecting Hadassah to be able to ventilate more than 100 to even to 200 patients in the next 2 or 3 weeks. So time is running out, and we have to find more and more beds and more equipment and more people to treat these patients.
Thank you. Before patients, or when patients have begun treatment or before they begin treatment, they need to be tested for this virus. And testing is proving to be a challenge all over the world right now in terms of the availability of kits, in terms of the rapidity or a lack thereof with which those test results can get returned. And many different companies are working on creating better and more quickly responsive testing kinds of materials. I wonder if you could give us a quick update on how testing is going in Israel and how HMO is participating in that effort.
So it's interesting how this evolves. First of all, it was only for very, very high risk people who came from high risk areas in the world, and people who were developing symptoms. Those are the only ones who were allowed to be tested. It was soon evident that this is not enough, because we started seeing people who caught the virus without a known source. So once you see people who catch the virus without a known source, it's quite evident that it's in the community and you don't know where it's coming from, because people can infect you but they're asymptomatic, so you don't really know who's sick and who's not. So then there was a lot of political pressure on the Ministry of Health to broaden the testing, even to people who are not necessarily high risk. They did not come back from France or Italy, but they feel sick, and they want to be tested. It took a little bit of time to expand the laboratory capabilities from one major laboratory in Tel HaShomer. The second was in Hadassah. Hadassah picked up the challenge to open a corona detection lab, to now to more than 25 labs across the country who are enthusiastically testing everybody who wants to be tested. In Hadassah, Professor Rothstein actually he was the first to actually test the medical and nursing teams. About 10 days ago, we were all provided with kits to be tested for coronavirus, regardless of whether we had risk factors or side effects. Everybody was tested so that he knew who was positive and who wasn't, and he could quarantine the healthcare workers who are positive so that they don't infect the other healthcare workers and obviously the other patients. This caused a lot of unrest in the Ministry of Health because it was against what they advised. But I think people are starting to understand that that's the best way to know who's positive and who isn't, and to quarantine them very, very early on. We recently, as you said, we heard about a nurse in the emergency department who was infected. There was also a nurse from one of the other intensive care units that is now diagnosed as positive. It's very crucial that we diagnose very quickly and broadly as many people as we can. The other aspect of testing that is now becoming more important is the immunology serology testing, which means that we want to see who developed antibodies to the virus, because we know that whoever developed antibodies to the virus is probably protected and can go back to work, and also may even provide other patients or other potentially high-risk patients a vaccine, or at least not a vaccine, but immunoglobulins that are targeting the coronavirus to stop them from being infected. So this is now in the middle of being developed by many, many laboratories in Israel and around the world to try and diagnose as many people and maybe even see who can go back to work.
Okay, thank you, Professor Sviri. I want to make a couple of quick notes because there are a few questions that I don't think we're going to be able to get to, but I want to respond to them myself very, very quickly. Earlier, Roz Meyerson raised a question about what research is being done in looking for a vaccine or better therapies or anything else. Actually, just prior to this call, I was speaking with Gidon Melmed, one of our colleagues in Israel, and he and his colleagues are preparing an update from the R&D department at Hadassah that will detail about what we think are 6 or 7 projects that are underway right now on the development of all kinds of therapies for COVID-19. And we'll be reporting more upon what those developments look like over the coming couple of days once we have that information in hand. I do want to point out that in addition to the opportunity to hear from Professor Sviri this morning, Dr. Yoram Weiss was also featured on CNN this morning. If you don't know Yoram, not only is he a wonderful human being and an amazing doctor, an anesthesiologist by training, he's also the head of the Ein Kerem campus. And he was interviewed, it was a brief interview, but he was interviewed this morning. It's already been featured, I think, twice on CNN in different segments. And we are working on getting links to that video that we can share with all of you. Those of us who know and work with Yoram, it was pretty great to see him up on CNN today, representing our organization, our hospitals in the fight against this effort. We are coming up on the end of our hour. I have a few quick closing remarks and then we'll be finished. First and foremost, sincere and heartfelt thanks to you, Professor Sviri. Your time, your expertise, your humanity in approaching everything that we threw at you in the way of questions and in presenting a quick update on what's going on in the ICU and the round building has just been extraordinary. Thank you so much for that.
Thank you for inviting me.
Sure. For our audience today, a couple of quick things. One, as I mentioned earlier, we are working on our next call of this type for about 2 weeks from now. We'll be promoting it very, very soon once we nail down the speaker and the timing and all the other details that go along with it. There are several emails that we are sending out to our membership and our donors including a new one called Hadassah at Home, which is coming out once a week, which is presenting a series of ways for people all around their country to remain engaged with our organization and with each other as our Hadassah community. So please be mindful of that message because it contains a great deal of helpful information. And in closing, I will just say two quick things. One, I was monitoring the chat and exchanging a few messages with Susan Shakura, my friend and my colleague, and my fellow keeper donor. And something Sue said that really stuck with me in that chat message was that people who will consider being donors in support of our emergency fundraising efforts are literally becoming partners in saving lives. And I think based on what we all heard from Professor Sviri this morning, that is an absolute fact. So thank you for putting that idea in all of our heads, Sue. And then the last thing that I will say on my behalf, on behalf of Vivian Kovacs, the coordinator of the Philanthropy Division, and Ruth Ann Friedman, our vice coordinator, everybody on the staff, Janice Wyman, our CEO, Rhoda Smollow, our president, really to extend the warmest, sweetest, and safest and healthiest possible Pesach wishes to everybody coming up over the next week or so. We hope that your celebrations, while being appropriately socially distant, are also loving and filled with great times. Professor Sviri, thank you again. And to everyone who joined us today, thank you as well. We'll see you next time.